Okay, thank you for the kind introduction, Bruce. Good morning, everyone. So today I would like to present on our research topic on QI for stigma and discrimination in healthcare setting. For information, this was a collaborative effort led by the Ministry of Health in partnership with Malaysian AIDS Society, and also we got support from the Southeast Asia HIV Stigma Reduction QI Network. So I declare no conflict of interest for this presentation. And just a brief introduction on the global prevalence of the SND, whereby it ranged from the 19% to 88%, which is quite high. While locally in Malaysia, there's one study, limited data, but there's one study done on one facilities, health clinics, whereby the results stated that 23% of PL-HIV experienced stigma, and 19% reported discrimination. So these highlight the need to address the SND among healthcare workers, as it is not the matter of ethics, it directly impacts health outcome of PL-HIV. And this hinders the progress of our nation in achieving the 95-95-95 target. So with that in mind, our objective is to assess the effectiveness of QI intervention in reducing HIV stigma, as well as to determine the key predictors contributing to the negative healthcare worker attitudes. So for this study, we adopt a QI methodological approach, which was conducted in 3 phases from 2022 to 2023, whereby at the baseline period, we collect the data to verify the magnitude, as well as to identify the root cause of the SND, and to formulate the interventions. This followed by the 6-month intervention period, and subsequently post-intervention, where monitoring and evaluation was done. And healthcare workers around across the 55% health facility in Malaysia, across all the states, were recruited via purposive sampling, and we recruit all the healthcare workers who are able to understand Malay and English, and we exclude those who are on leave. And for the data collection, we use a self-administered survey via Google Form as a tool, and this one is adapted from a study by NIBLAD and validated, and the tools measure 8 components of SND indicators, which covers the domain of fear, awareness, institutional factors, and attitude. And for the analysis, apart from descriptive, we also analyze the data using the Z test for indicator changes and logistic regression to determine the predictors. So just a little bit of info about the information strategy that we use in these studies. The intervention studies, we divided into 3 categories, which target structural, process, and personnel. And all the strategies that have been implemented by the facilities are then compiled and documented and are accessible via the Ministry of Health website, as well as you can access it via the QR code here to see all the strategies that has been done in the health facilities in Malaysia. And in terms of intervention strategy covering the structure area, we established the task force for the facility level to oversee and also to coordinate all the stigma and discrimination intervention. We designed a specific day for delivering healthcare HIV service, and we redesigned the clinic flow to promote patient confidentiality. And in terms of process, we remove the disease identifying stamp, for example, the label of biohazard stamp on the lab form, and we implement a single glove policy for the blood taking. Instead of calling PL-HIV by their name, we call it using our special queue number, and introduce patient experience survey to gain feedback and to foster a more supportive and non-stigmatizing care environment. So in terms of personnel, we did some strategies which include providing interactive and improved training mode, and also improved training content to all the healthcare workers. We use multimedia messages and other media social platform to reinforce the key messages, as well as we strengthened adherence support service through peer learning. And we also established a support program so that PL-HIV can connect with the public and other relevant agencies. So as a result, these are the characteristics of our participant profile. Majority of them age about 31 to 40 years old, and most of them being female and have been working around for 11 to 20 years. In terms of work department and occupation, they came from a mix of department, predominantly from the outpatient department, and work as nurses. This demographic shows that the importance of addressing stigma and discrimination at the front line of care, because they are the one who form the backbone of the public healthcare service in Malaysia. So these are the results that we get from after the intervention. And post intervention, we observe statistically significant improvement in 6 out of 8 indicators, and we can see from here that indicators number 1, number 2, and number 3, which reflects the domain fear, show significant reduction of and improvement, indicating reduced fear among healthcare workers during service provision. And we also saw increase in reported availability of guideline, as shown by the indicator number 7, suggesting improved institutional support. And in terms of attitude, which depicted by indicator number 8, we reflect healthcare worker views on pregnancy among PLHIV, also shown in significant improvement. However, we can see that despite the intervention done and despite the progress, the level of S&D still persists and remain an area of concern, suggesting that there are deep-rooted moral attitudes that we need more time to take and sustain effect to change. So in terms of logistic regression, to answer our objective number 2, who are at risk? So according to our result, it revealed that several key factors can significantly affect the negative attitude. For example, older healthcare workers, those who have not directly involved in HIV care, and those who had not received prior S&D training, and non-medical doctor were significantly more likely to exhibit negative attitude compared to the reference group. So these findings highlight where we could focus our research in the future by tailoring S&D training to group that needs desensitization. So as a conclusion, we successfully reduced the S&D among healthcare workers using a structured, scalable QI, tailored to each facility together with the involvement of multiple stakeholders. However, the S&D level is still there, which suggests area for improvement. So future training module or HIV desensitization program targeting this key risk factor could be further reduce the S&D. So next step, actually the intervention made a clear positive impact, but more work needs to be done. Therefore, the next step are to roll out long-term behavioral intervention, because as we know, addressing stigma and negative attitude requires a long way. And additionally, there also need to institutionalize stigma training and monitoring improvement via routine monitoring indicator. So before I end my presentation, I would like to thank all those acknowledged in the slide for their valuable contribution in the study. With that, I thank you.